Good day to all. Thank you, Dr. Jeev today, Dr. Walke, and all the PCDA office bearers. I have to just say that I'm not a physician, not a cardiologist, or a surgeon. Basically, I'm an anesthesiologist with 30 years of experience as a freelancer. I also have 24 years of teaching experience in Pune Municipal Corporation hospitals. I also did general practice in our Walke nursing home in Aun for some time. Basic agenda today is medical legal safety in our practice. The questions considered in court of law in case involving family physicians. Was the clinic equipped to undertake the concerned procedures? Was anaphylaxis managed as per protocol? Was basic life support given if the patient crashed? Supreme Court expects every clinic to give life support to every emergency and road traffic accidents. Cross-pati and cross-specialty practice is beyond the scope of this presentation and my knowledge of medical legal aspects. In other words, courts look for presence of standard list of drugs in family physicians' clinics, standard list of instruments and equipments, protocols for management of cardiac arrest and anaphylaxis, and protocols for managing other conditions or other diseases. The question is, are such standards and protocols mentioned in some law book? The answer is no. Courts expect associations like us to decide that for their members. This small presentation is the first step towards that activity of PCDA. Today, we will initiate brainstorming on minimum requirement of drugs, instruments, and equipments. Experts like physicians, cardiologists, and surgeons can help us devise standard protocols for practice. I will spend some time to discuss my take on LMA, that is laryngeal mask airway, and use of Xylocard during the course of this presentation. To start with, we'll talk about drugs. In addition to the drugs and medicines that you routinely keep in your clinics, we need to have certain drugs which are important, such as atropine, adrenaline, soda bicarb, hydrocortisone, dexamethasone, Avil, a few cardiac drugs like sorbitrate, Rosavage, ecosprin. I think the cardiologist and your physicians will help you to actually let you know what are the drugs that should be used. Now, when we are talking about Xylocard, now why Xylocard should be kept in our clinic? You must be having Xylocaine 2%. You must be having Xylocaine with adrenaline, which comes in 1 lakh solution of adrenaline. But what I want to suggest that Xylocaine 2% and Xylocaine with adrenaline can cause untoward reactions in a patient because they contain methylparaben as a preservative. Now, why Xylocard? Xylocard because it does not contain methylparaben. We as anesthetists use Xylocard very frequently when we are giving drugs like propofol. Now, Xylocard is given in also conditions where there are arrhythmias, where there are ectopic beats or missed beats. So, Xylocard is one drug which can be easily given as a local anesthetic in case you are doing some suturing in an emergency patient. Even if Xylocard accidentally goes into a vein, there will be no untoward reaction to this drug. That is why Xylocard should be in and Xylocaine 2% and with adrenaline should be out of your clinics. Now, when we talk about equipment, in addition to our usual list, what we need and is a must is an oxygen cylinder. Now, only having an oxygen cylinder is not going to be of any use because if you do not have a pana or a key to it to open the oxygen cylinder, it's of no use. Now, any oxygen cylinder, whether it is a standalone cylinder or it is attached to a anesthesia machine, every cylinder will open in an anti-clockwise direction and will close in a clockwise direction. This you have to teach your staff very clearly. It is very easy to open it. But they have to remember to open it anti-clockwise and to close it clockwise. Check whether the cylinder is full or empty at least once in 15 days. Whenever a new full cylinder comes to your clinic, see that it is properly closed at the top, and you mention the date and time that the cylinder had come to your clinic. Next, with an oxygen cylinder, you need a venti mask and a water bottle, which is easily connected to your oxygen cylinders. With the venti mask and water bottle, we also need what is very important is an ambu bag. Ambu bag with a mask, with a no return valve and an oxygen connector. You also need a BP apparatus, you need a glucometer, you need a pulse oximeter, you need a nebulizer, and in case you also happen to have an ECG machine, it will be very good. There are some physicians or some general practitioners who do have an ECG machine, and that is very desirable. When we talk about ambu bag, you can see there are two pictures here. One is a pic of an ambu bag with a blue color no return valve with a black color of face mask. Now this ambu bag is a 2-liter bag which is used for males and females. There is an oxygen connection at the end of the ambu bag and a soft plastic bag which is a oxygen reservoir. Now on the right you can see there is a venti mask there are two ends of the tubing, one which connects to your oxygen cylinder very easily and one which is attached to the face mask of the patient. Now if you're dealing with small children, I think you should have an ambu bag which is 250 ml capacity. What we are seeing here is a 2-liter bag, and you should also have a small face mask. The valve will remain the same, but you should have a smaller mask and a smaller ambu bag. Whenever you're just ventilating with one hand and one puff you're giving almost 500 ml air to the patient, which is enriched with oxygen. And this bag that you're seeing is a silicone bag. It will be very nice if you have this silicone bag, ambu bag, because it is very long lasting and it is very difficult to prick this bag. So it is going to be worth the price that you're going to pay for it. And I don't think it's very costly either. So now in big hospitals, whenever there is a patient which has crashed right in front of the entrance or in the corridor, they initiate a code blue and patient is revived with the help of a crash cart which is fully loaded. Now these big hospitals have crash carts. We can definitely have our own fully loaded emergency trays. Now what this emergency tray should be, emergency trays should be having all the emergency drugs that have been given by your physician and cardiologist. We should have IV fluids such as ringer lactate, dextrose normal saline, 25% dextrose, and normal saline also. We should have scissors, sticking plasters, ampule cutter, disposable gloves, betadine, spirit, IV sets, intracats, syringes of 10, 5, and 2 cc syringes, lignocaine jelly. Whenever you find that some patient has crashed, all you have to say is, sister or brother, get the emergency tray. And that should suffice. You will have everything into that tray. Now, if you are facing some respiratory arrest in your clinic, you find a patient just comes in your clinic and he just collapses and he is not able to breathe. Would you be comfortable giving mouth to mouth respiration? And that too, if you are a male, it will be difficult for you to give mouth to mouth respiration to the opposite sex, and vice versa. Are you trained in intubation? I don't think many of you will be trained for intubation. And I don't think it is expected also. But to solve this major problem, whether we should be able to intubate or not, which is a little difficult in an emergency situation, even for us sometimes, we have something what is called as a laryngeal mask airway, LMA. Now, this comes in different sizes. At our clinic, we can have size number 3, which is good enough for a male or a female patient. It is very, very simple and easily insertable by yourself. You can always train your paramedics, your sisters, your maushis, your brothers, anybody in your clinic who is working with you can be easily trained to put in an LMA, which will save a patient. Now, if you're dealing with small children, so you can have sizes of 2 and 2.5 also. This also comes as a silicone mask, which is silicone mask airway, which is also long lasting. All you have to need to check is the balloon that is there, and you need a 10 cc syringe to inflate the balloon. And you need lignocaine jelly whenever you're using this laryngeal mask airway. So this is so simple that we have trained gynecologists to put in an LMA in a gynec conference. If so many, if gynecologists can be trained, you can definitely be trained. So if you are facing a cardiac arrest or a anaphylaxis case in a court of law, you need to prove by written documents that cardiac arrest or anaphylaxis was indeed managed as per protocols within the limitations of your clinic and the ability as a physician, as a family physician. Presently, clinics may not be expected to have monitors and defibrillators, but in future it may be. Printed and laminated protocols are available. They are in big writings, which is easily readable and easily doable. So these protocols of cardiac arrest and anaphylaxis management should be pasted on the walls of your clinics, which is very, very important. The carry home message is to develop a PCDA recommendation for minimum required drugs list. As I told you, the drugs should be checked every month for the expiry dates. Minimum instruments and equipment list. Again, check for the oxygen cylinders. When did it come? Whether it full or not. Again, protocols for managing routine procedures and complications. Thank you for this patient listening. But to mention something very important, when we are talking about inserting an LMA, it would be very nice if PCDA arranges a basic life support program wherein we can have a mannequin to put in an LMA. There is a simple mannequin which has only insertion for an LMA. There is one more mannequin where you can put in an LMA and ventilate the patient, because they have a trachea, there are lungs over there, and you can easily ventilate and see whether that LMA that you have inserted, are you successful in ventilating the patient with an LMA or not. And it is very, very easy to do. Again, I'm telling you, we should have this program, and PCDA should encourage such programs. Thank you very much.